So what PAN does? PAN facilitates integration of evidence-based nutrition intervention into the core matrix of healthcare by empowering healthcare professionals and facilitate evidence-based education, nutrition education in medical schools. PAN provide guidance to policymakers and industry players to designing strategies and products to create better food systems and achieve nutritional equity. PAN involves the international medical community in activities for furthering know-how on healthy eating environments and food systems. And PAN India increase knowledge integration and sustainability of programs and projects through partnerships and collaborations. PAN creating a public awareness through educating public through community outreach activities. Now, coming to PAN's mission, PAN India aims to be the catalyst in the revolutionizing the healthcare into a whole person care model with evidence-based nutrition at the core matrix. Our mission is to address the multitude of issues related to dietary choices of people in India by facilitating a better healthcare system, healthier and a safer food environment, and a public awareness. Now, I would like to give a brief introduction of our leadership board. On our leadership board, we have Dr. Nicholas Oppenrider, MD. He is a co-founder and a current chairman of the board at PAN International. We have Dr. Alan Kornberg, MD and MBA. He is an advisor to PAN India. And we also have Dr. Regina Shahin, ma'am, who is a medical director of PAN India. In addition to this, there is a strong medical PAN team structure, including doctors, nutritionists, who contribute as a program manager, ambassadors, volunteers, and also international team who are actively involved at a various capacities. Doctors, faculties, or medicos who would like to get associated with PAN can join us at a various capacities like ambassadors and volunteers to help us the mission forward. Now, I would like to introduce today's panel. On our panel today, we have Dr. Anjali Nakra, ma'am. She is a family physician and has international board certification in lifestyle medicine. She is certified for obesity management by the World Obesity Federation. She is trained in mind, body, and medicine and motivational interviewing and cognitive behavioral therapy in insomnia. She is the founder of Path to Health Clinic, a member of American College of Lifestyle Medicine, and a co-author of the book How Healers Heal. Welcome, ma'am. Our next speaker is Dr. Suresh Bhagia, sir. He is an international cardiovascular surgeon with a passion for lifestyle medicine. He stands at the forefront of medical innovation, blending cutting-edge surgical expertise with a holistic approach to wellness. He has 28 years of medical expertise and author of Amazon bestseller titled Bypass the Coronary Bypass Surgery. Sir has helped 600 plus patients till now in with coronary artery disease and diabetes reversal. And he actively promotes lifestyle modifications such as healthy eating, regular exercise, stress management, and smoking cessation. He is an educator and a thought leader, has contributed significantly to medical literature, sharing his insights on advancement in surgical techniques, lifestyle intervention, and the evolving landscape of cardiovascular healthcare. Sir prefer to call him as a Karma Yogi on the path of salvation through holistic healing of chronic lifestyle diseases via lifestyle medicine applications. Welcome, Dr. Suresh Bhagia, sir. Now, we have our next speaker, Dr. Achyutan Ishwar, sir. He is a co-founder of Sampurna Ahara, PSC Lifestyle Clinic, and a nutrition science.in. He has bachelor degree in naturopathy and yoga science. He is highly motivated to empower people to adopt a whole food plant-based diet, that is WFP diet, and enabled reversal of diseases like hypertension, type 2 diabetes, fertility-related issues, and a few others simply by having patients change their lifestyle habits. Its PSC Lifestyle Clinic is open to folks who wish to heal themselves and lead healthier lives, conduct workshops called Healing with Food, and shows practical ways of cooking using healthy principles. Sampurna Ahara is a healthy kitchen that provides WFPB lunches and dinners as a tiffin delivery services and catering. Welcome, Dr. Achyutan Ishwar, sir. Now, our next speaker is Dr. Varsha Shah ma'am. Varsha Shah ma'am is a practicing pediatrician with a special interest in adolescent medicine and lifestyle medicine. She is consultant at SBKS Medical College. Ma'am is a medical consultant at Sharan, an organization which helps people in disease reversal. She is consultant at Prakruti Heal for disease reversal and holistic healing. Ma'am is currently pursuing PGDLM, that is postgraduate diploma in lifestyle medicine from CMC Vellore. Ma'am is passionate about children and adolescents' well-being, which are the future foundation of our country. Welcome, ma'am. Now, our next panelist is Dr. Rajendra Ramagiri, sir. Dr. Rajendra did MBBS from SV Medical College, Tirupati. He has masters in emergency medicine from Care Hospital, Hyderabad. He is a critical care fellowship. He has done critical care fellowship from USA certification in plant-based nutrition from Cornell University, USA. He is a member of Indian Society of Lifestyle Medicine. He worked in a corporate hospitals like Apollo Care Hospitals as an emergency physician, and he is also the founder of Dr. Rajendra's Lifestyle Clinic in Banjara Hills, Hyderabad. Dr. Rajendra, sir, welcome to board. Now, our last speaker is Dr. Miss Supraja S. ma'am. Supraja ma'am is a nutritionist and a holistic health coach. She believes that good health is the result of achieving equilibrium in all aspects of lifestyle medicine. She is also a certified sports nutritionist and holds a certificate in music therapy. She is a life member of Indian Dietetic Association, Mumbai chapter, and a member of Indian Society of Lifestyle Medicine. Ma'am is the founder of Own Your Health, where the focus is to nourish the body and nurture the mind. She is also nutritional consultant with Sharan. And Supraja ma'am is passionate about helping people prevent or reverse lifestyle diseases like obesity, diabetes, polycystic ovary syndrome, and she believes lifestyle changes should be the first approach and that medication should be the last resort. Welcome, ma'am. Now, I would like to request my colleague, Dr. Deshna ma'am, to continue with today's topic introduction. Ma'am, over to you. Deshna ma'am.
NPD kindly emphasize replacement. Thank you very much for my introduction. Thank you very much for your patience listening.
Dr. Prasanna, can you please mute yourself?
Next speaker. Thank you very much for that.
Deshna, we can't hear you.
Deshma ma'am, are you there?
I think Deshna is having some issues with her audio.
Yeah, we can't hear her.
Yeah.
Give me a minute.
Deshna, if you're on two devices, you might need to.
Yeah. Hello?
Police was not here.
Hear you now.
Oh, really?
Deepali, you are on mute.
Unmute yourself, please.
Yeah, this is Deshna. Okay. Diabetes is a chronic disease that occurs either when the pancreas does not produce enough insulin or when the body cannot effectively use the insulin it produces. In India, there are estimated 77 million people above the age of 18 years suffering from diabetes. and nearly 25 million people are pre-diabetics. More than 50% of people are unaware of their diabetic status, which leads to health complication if not detected earlier. Type 2, with this, diabetes has got a lot of chronic complication, and type 2 diabetes remission is when your blood sugar levels return to a safe non-diabetic level long term without the need for glucose lowering medication. It stops diabetes in its track and boosts your chance of healthy future. We know that nutrition plays an important role in diabetes management and remission. Let's see what does the current evidence say on role of nutrition in diabetes remission. With this, I would start with the first question to Dr. Rajender. The question is, what is diabetes remission? When could we say that the patient is in remission? Also, please explain how remission works. Does it imply a reversal of the condition? In other words, is this a one-time work? Over to you, sir.
Okay. Will you please allow me to share the screen? If you stop sharing the screen, I will be able to share. So I want to show the slides. If you stop sharing, I'll be able to, so I can go ahead. Dipali, you
Nitesh sir, could you please stop sharing the screen? Actually, sir, we don't usually allow the panelists to share the screen, because then the time set is for 3 to 4 minutes.
okay.
But yes,
Okay.
please try to complete it in 3 to 4
Fine.
minutes. Thank you, sir.
No worries. Okay. So before we discussing about the diabetic remission, let us understand the typical journey of diabetic patient. So they will be started with a low dose of drugs, and as the time proceeds, the dose of drugs will keep on increases, and they'll be started on insulin when the body is not producing insulin, and eventually they face long-term complications. It is a typical journey. So what is remission? In the remission, what is happening is we are going in the exact opposite direction of the typical journey of diabetic patient. That means we are helping the patient to reduce the sugars and reduce medication and prevent the long-term complications that happens with the diabetes. As per the American Diabetic Association, if you see here, so what is the actual definition of remission from as per the ADA? If the person is not on medication for a period of more than 3 months and maintaining the HbA1c less than 6.5, then we can consider that the patient is in the remission phase. Okay. So is everybody is fit for remission? No. So there's an age criteria, and there are certain criteria that will decide whether a person can be fit for remission or not. So the good fit for the remission is if a person diagnosed with the diabetes in less than 2 years of time, they are good fit. And the age of the patient is less than 50 years. And if they are having the better glycemic control, the HbA1c and the fasting and the post sugar control, and if the patient is on lesser medication, so, and if the person got the diabetes because of the overweight or obesity, and if their body is producing sufficient insulin, all these factors determine whether the person is good fit for the remission. And most importantly, the person should have the strong motivation. Why? Because when we are talking about the remission, they need to make a lot of changes in their habits. That means 6 pillars that we talk in the lifestyle medicine. They need to make changes in their diet, exercise, sleep, stress, and alcohol intake, and the relationship and the emotional health. They need to work a lot to reverse their diabetes, right? It's not an easy game. So the person should have a strong motivation, a strong emotional reason to work on remission. And then who is not fit for the remission? If the person got diabetes, it's been like more than 10, 15 years. And if the case is because of the pancreatic calcification, or the C-peptide is very poor, there is no insulin production, such kind of cases we cannot reverse. And the age is more than 60, 65, 70 years. And somebody who is already facing complications, somebody who is already on dialysis, or already facing retinopathies, okay, neuropathies, such kind of cases we cannot think of diabetic remission. Okay. Next question, as you asked, why should we think of remission? Why? Because as we know, diabetic causes a lot of complication. It increases the risk of CVS and the heart attacks and the kidney failures and all. So when we are able to reverse, when we are able to come into the diabetic remission phase, we are able to prevent or reduce the risk of all these complications. So that's why we need to focus on diabetic remission. if there is a possibility in the cases. Another thing is there is a Times of India survey that concluded that an average diabetic patient is spending 15-20 lakhs for medication, hospital admissions, and complications, and kidney failure, stenting, bypass, and all. So when we are helping a patient in the diabetic remission, we are saving 15-20 lakhs of rupees. So that is another important thing. And another thing is there is a Lancet article that is published in Telugu. So that is concluded that if a person is getting diabetes in 30s, that is reducing the lifespan by 14 years. If somebody is getting diabetes in 40s, that is reducing the lifespan by 10 years because of the complications and the internal damage that is happening. So when we are able to reverse the remission of diabetes, we are able to extend that lifespan. That's why we need to focus on remission if there is a possibility to do that. As I have mentioned about the who is fit for the remission. And yeah, as you asked, is it one-time work? No. So if we are stopping the drugs in any case and bringing down the HbA1c to below 6.5, that is not the end game. That is the beginning. Why? Because if a person thinks that, yeah, I'm out of medication, mera to diabetes khatam ho gaya, and start again eating the unhealthy foods and no physical activity and sleeping late nights, again, there's a possibility of reoccurrence. Re-reversal will happen. So they need to sustain the lifestyle which brought them the remission. At least 80-90% of the lifestyle, if they sustain, will be able to prevent them again landing in the diabetes. And yeah, so I worked in the corporates for 6-7 years. I have seen thousands of cases getting into the complications and all. Then I felt that we can help them when we are in the beginning phase of their diabetes. We can help them in the remission. That's why I switched into lifestyle medicine for the past 3-4 years. I'm practicing it where we are able to help hundreds of patients in the remission. In the young age, the good thing is in the young age, we get amazing results within the months of time. I have hundreds of cases where we are able to stop the drugs, reduce medication and all. But the commitment of the person is very, very important.
Thank you so much, sir. Dr. Achyutan, sir, do you?
Krishna, you're not audible.
Vindhya ma'am, can you please take over?
Dr. Achyutan, sir, do you want to add anything on the first question?
I think that was fantastic and honored to listen to Dr. Rajendra. Nothing from me to add.
Thank you so much, sir. Dr. Vindhya ma'am, you can continue with the next question. Thank you.
You need to unmute yourself, Vindhya.
Oh, sorry. Hi. Good evening, Supraja. So the second question goes to you. So there is a rising body of evidence that lifestyle modifications, when followed intensively, can help achieve optimal control of diabetes and even diabetes remission. Could you please provide some insights on this topic, particularly the evidence-based nutrition? And if possible, could you perhaps offer our physicians some basic guidance for incorporating these approaches into their practice?
Thank you, Vindhya, for that question. So like Dr. Rajendra mentioned, right, definitely remission is possible and there are enough and more studies to talk about it. And I'm sure most of you have come across, and I think Dr. Rajendra mentioned it in his slide, right, the direct study which was done in the UK, you know, and that same study actually was extended to a 5-year period called the new direct study. Right. And they still saw that, you know, while the percentage remission was much lesser, because obviously there are lots of factors, but definitely remission continued in, you know, quite a number of cases. Apart from this, there was the Diadem study, which was conducted on the Middle Eastern and African population in Qatar, the Diadem 1 study. Now that over a period of 12 years again showed that remission is possible. So quite early on itself, we have seen studies which talk about control of diabetes. Very recently, you know, we had, of course, Dr. Pramod Tripathi, you know, in India, when it comes to our Indian population, we had Dr. Pramod Tripathi talk about the holistic, let me just get that, the holistic transformation program, right, on type 2 diabetes remission. So he's done it over a 1-year period and he's seen significant remission in about 30% of the cases. Now, all of these studies, if you look at, there's also a very, relatively not heard of study which was done by, I think, the Vaishnavi Institute of Medical Sciences in Bangalore, which spoke about, a calorie deficit diet. So across, when you look at all of these studies, right, everybody focuses on a low calorie, a low carbohydrate, a calorie deficit. These are the terms that you typically come across when we're talking about diabetes remission or control of, diabetes. Now, there are one or two studies which, apart from low calorie, also focused on physical activity. I think there was also an ICMR India diabetic study which spoke about macronutrient composition. So again, when it comes to food, I firmly believe, based on my personal experience, and of course, taking all of these studies into consideration, that calorie deficit definitely works, right? But is it sustainable? When you're doing studies in a controlled environment, when there are a lot of factors, people who are able to monitor and guide you, it's definitely possible to continue to be in remission. But how do you get this into a practical setting, into your normal, regular lifestyle setting, right? And that is where I think the ICMR India diabetic study kind of focuses on, the composition of the food groups, right? So how much of carbohydrates, how much of protein, how much of fat, and what kind of composition would you want to continue on a day-to-day basis, which will help you with continuing your remission goals or getting your diabetes, sugar levels under control. So when you look at that study, and based on personal experience also, you will find that they're focusing on low calorie, right? Calorie deficit. Now, how is this possible in a practical scenario? By focusing on cutting out refined foods, cutting out ultra processed food. And just before we started off, I was talking with Dr. Varsha Shah, and I remember there was a longitudinal study on ultra processed food that was done, which spoke about inclusion of ultra processed foods increases the risk of diabetes by about 12%. So just primarily cutting out ultra processed foods, refined foods in any form, and cutting out extra fat, right? Because our body tends to store anything in excess as fat. So when we go excess on calories, we get into that, the fat storage happens. So when you are focusing on a low calorie deficit, or a calorie deficit diet, you want to focus on bringing in a lot of fiber. So as a physician, practically, if you need to look at what would you advise to your patients to get into a controlled mode or get into a remission mode, is to try and focus on whole foods. Why do I say whole foods? Because whole foods come with fiber. And when we're talking about fiber, of course, we're talking plant-based, right? Because no other foods contain fiber. So we're talking about whole food plant-based because fiber is the key component that helps you control those excess calories. And when you bring in whole foods, along with the fiber, then you're also bringing in a lot of nutrients that are coming in with, which are bound tightly to the fiber. And these nutrients help you feel, of course, we all know fiber makes you feel full for a longer time, right? The satiety value of food. So when you are feeling full for longer, you're not going to eat unnecessarily, and therefore your calorie count comes down. Now, the ICMR India diabetic study also spoke about, 50% on an average. Okay, so while they looked at pre-diabetics, they looked at normal glucose tolerance, and they looked at, the third category. Let me just, sorry, I kind of lost that. The third category was newly diagnosed diabetics. Yes, the newly diagnosed diabetic population. So across the board, in all of these three categories, the broad classification was averaging out between 47 to 54% of carbohydrates. So, if we can probably look at energy consumption coming from carbohydrates being at about 50%, about 18-20% coming in from proteins, and another 15 to 20% coming in from fats, you are going to be able to maintain this kind of a ratio in your day-to-day life, right? But what needs to be the focus from a practical application point of view is bringing in foods which are rich in fiber. Okay, so consuming whole grains, but cutting down on the quantity. Now, it's impossible for a normal man, even I don't do it, to sit and measure my portion and say, okay, I have 10 grams of protein or I have 20 grams of protein. So what we need to focus on is at least ensuring that we fill half our plate with vegetables and whole legumes, right? And a lot of leafy greens and fruits. So when you're bringing in these kind of foods, automatically your calorie component of your overall food plate comes down. And if you focus on even in grains, right, whether it's rice or wheat or whatever, if you focus on the whole factor, which is bringing in minimally polished or unpolished grains, grains in a more intact form, then you're cutting down on those excess calories which come in from the refined foods. And of course, there is no doubt that we need to stay away from ultra processed foods. Dr. Rajendra did mention, lifestyle factors, right? So in my personal experience, while food, yes, is the critical component, but food alone does not work. Like people could be having the best of control in their food, but if they're having stressors, if their sleep is not good, all of these are going to be influential in, putting your diabetes out of control, or, just stress or just lack of sleep could actually not, upset the entire apple cart. So you have to look at intense lifestyle modifications, but more sustainable lifestyle modifications, which is bringing in whole foods, staying off the ultra processed refined foods, staying off animal foods, because they're high in fat. And here the whole, the concept of insulin resistance is about fat, right? So just cutting out these foods, bringing in whole foods, and of course, physical activity. Now, one small point I do want to add, that a lot of people are not able to do very focused physical activity, but just bringing in movement through the day, what we call NEAT, non-exercise activity thermogenesis. So just bringing in movement through the day is going to be beneficial in, controlling your sugar levels at a much better level. So it's already been covered. So the 6 pillars, just focus on eating the right foods, movement through the day, make sure you get good sleep, manage your stressors well, and have a very the emotional quotient of the patient in question is very, very important. If they have good social settings, then definitely this is quite doable. It's easily doable.
Thank you, Supraja. That was insightful. Anybody wants to add any points?
Yeah,
Yes,
may I?
yes, ma'am.
Dr. Varsha, please. There were a couple
Yeah.
of
No, I would just I see a lot of teenagers, like 15 years, 19 years, 21 years, developing pre-diabetes and diabetes, where they, as Supraja rightly said, it's basically the ultra-processed food. Now, how does the ultra-processed food lead to insulin resistance? See, what is ultra-processed food? It is industrially produced edible substances, which is known as food, with the main profit being, main aim being profit-driven, and it is designed to be overconsumed because it hijacks your brain reward system. Secondly, what happens is there are so many chemicals, like if you see, it is sweetness without sugar. So you have Diet Coke without sugar. It is creaminess without fat. And it's that savoriness without salt. So our body can, when you have something on sweet on your tongue, the tongue sends signals to the brain, and which in turn sends signal to the body to be prepared to receive glucose or sugar. So the body will release insulin. But because this is a 0-calorie sweetener, the insulin is still released because of that reflex, but there are no calories coming in. So what happens is insulin is produced, so there is hypoglycemia, so there is hunger. So all these diet, there's so much of mislabeling of foods, which lead, in fact, to weight gain rather than weight loss. And this, in the long term, leads to insulin resistance. So I have seen pre-diabetes in, say, like 10-year-old kids, diabetes also in like 14 years old, and their consumption is like very standard, it's those chocos with milk, bread butter sandwich. So chocos is basically nutritionally barren and calorically dense food. It is all the nutrients as just, because of the processing. When you remove the fiber, you can make it into any shape, that Mickey Mouse shape, that moon shape, the star shape. And then you add in the flavor of chocolate, which is artificial flavor. It is not really cacao. And then there are the stabilizers and flavor enhancers, which react with your gut microbiome and cause a lot of alterations. So the thing is, our routine breakfast has been hijacked with cornflakes and chocos and bread butter. Then you have that Amul lassi after lunch. And then you have, again, dinner is always fast food. Like, it's always a pizza or a burger or a sandwich or something of that sort, especially children living in hostels and all. So then you see weight gain, like I put on 10 kgs in last 1 year post-COVID. So that leads to insulin resistance. That is one of the main causes in other than animal food. That's it. Thank you.
Thank you, ma'am.
Thank you.
Deshna?
Thank you so much. My question is to Dr. Varsha ma'am again. While lifestyle changes can help in diabetes remission, there is documentation that other therapies such as GLP-1, receptor agonists, intense insulin therapy, bariatric surgery, or other intervention can also remit diabetes. In terms of diabetes remission, is it possible to compare all of these modalities and identify which is the most viable choice for people with diabetes? Also, if possible, please elaborate on all these modalities. Thank you. Over to you, Dr.
Yeah, thank you, Deshna, for the opportunity. I will first elaborate on these modalities and then we'll compare. Okay. So we have this latest is the GLP glucagon-like peptide 1 receptor agonists, which you have the oral and the injectable. So injectable is like very convenient because it's once a week. Oral, you can take it once or twice a day. Okay, now how do these act? Now, GLP receptors are present on your pancreas and your intestines and your brain and your liver. So it acts on those receptors and prevents the degradation of that glucagon-like peptide, which is a very potent hormone. And that hormone triggers the release of insulin from pancreas. It blocks glucagon secretion and prevents release of glucose from the liver into the bloodstream. It causes satiety because the food is retained in the stomach for a longer time and it sends signals to your brain inducing satiety. Now, why these drugs are good? Because one, they act by multiple mechanisms, Your caloric intake goes less, your sugars, insulin releases there, it blocks the glucagon. Plus, it is more useful in patients who have underlying heart disease, who have obesity. It is supposed to prevent progression of diabetic nephropathy. And of course, it improves fatty liver and then improves even lipid metabolism. Now, if you go to the adverse effects, the most common adverse effect of GLP-1 receptor agonist is the gastrointestinal. There's, nausea, vomiting, diarrhea, indigestion, abdominal pain, and it can lead to gastroparesis, basically because it decreases stomach emptying time. So what happens is the contents are there in the stomach for a longer time, so you feel satiated for a longer time. Now, this gastroparesis at times leads to abdominal distension and vomiting, and you may land in the hospital at times. Because I've had one patient from Dubai who was actually started on this injection, Ozempic, for obesity with pre-diabetes. And at the end of the 3rd week, she lost around 10 kgs and she was admitted for gastroparesis. So the dose was she was started on a low dose, but she could not tolerate that low dose. Okay. Second is some severe side effects. It can cause acute pancreatitis, acute cholecystitis, acute kidney injury. It can cause allergic reactions. And if given along with other oral glucose lowering agents, it may cause even hypoglycemia. Okay. And lastly, it is contraindicated in all patients with family history of medullary thyroid carcinoma, because when it was tested in rats, there was propensity or propagation of that medullary thyroid carcinoma. So this is where this is GLP-1 agonist. Now, the biggest disadvantage for our patients, it's extremely very costly. 10 tablets would cost anywhere between 3,000 to 5,000 rupees. So it's like 300 rupees for one tablet. Secondly, it is not the solution. We will come to it later on. And injectable, again, it can cause injection site reaction, skin infection, inflammation. Then we have intense insulin therapy. Now, intense insulin therapy ideally is for IDDM, that is insulin-dependent diabetes mellitus, that we see in children. I see in children that where oral drugs are not effective. So what is intense insulin therapy is you try to mimic the body's insulin response. So the body always releases some basal insulin, which keeps your blood sugar under control. And with each meal, there is a surge of insulin to control the post-meal sugar rise. Okay, so insulin is released from the pancreas and it has a half-life of say 5 to 6 minutes, but in the cells, it acts for 1 to 2 hours. So you have insulin, you have different types of insulin. You have the regular insulin and you have the Lispro and the Aspart, which are the fast-acting insulins or the short-acting insulins. And then you have the long-acting insulin, that is the Lantus and the Levemir and the Tresiba, which are the long-acting insulins. Now, the short-acting insulin, the Lispro, what we use in children, the effect is within, say, like 5 to 15 minutes onset of action. Peak it is as around 1 to 2 hours, and duration of action is around 4 to 6 hours. Regular insulin is around 30 minutes more. Okay. Then the Levemir, the long-acting insulins, the action, onset of action is at 1 hour and the duration is between, say, like 20 to 24 hours. For Tresiba, it goes even higher. It may be up to 36 hours. So this is, so what you do is with, you give a basal insulin. So how do you calculate the dose? Now, the total dose is calculated like what we use is body weight into 0.6, that is the total insulin dose. Then 40% of it is approximately the basal insulin and 60%, 50 to 60% is the regular insulin or the short-acting insulin. So suppose I have a, say, 60 kg adult, you multiply it by 6 are 36 units, so 40 units is the requirement. So approximately 18 to 20 units will be the basal insulin and 20 units would be the short-acting insulin in 3 doses. So with breakfast, with lunch, with dinner. And then you monitor it and then you add the correction dose. If like, depending upon the carbohydrate insulin ratio. Now this carbohydrate insulin ratio, if you follow it along with lifestyle medicine, it goes on increasing. So see, 1 unit of insulin is for how many grams of carbohydrate, like 12 grams, 10 grams. And then that ratio, as your insulin sensitivity increases, that ratio improves. So that ratio may go up from, say, 10 grams to 1 unit to 20 grams to 1 unit. Means you are improving on that. Now, what is the advantage of the system is, you have the freedom to eat when you want. You can control for the exercise, the stress. And in adults, what happens? Suppose if my sugar is 300 and my target was, say, 150. So I'm 150 excess. Okay. And if my 1 unit insulin lowers the sugar by, say, 50 points, then I take an additional dose of 3 units. Bring my sugar down. And if I'm not hungry, I can eat after 2 hours when my sugar touches 120 or 150. So that's the advantage of the system. But a lot of it requires a lot of mathematics and calculations initially. And later on, as you get adjusted, it is there. Sometimes if you don't eat, it may cause hypoglycemia, and sometimes it even may cause hyperglycemia. So we always teach our patients to identify symptoms of hypo and hyperglycemia. Okay. So that is about intense insulin therapy. Now, there are papers which say that intense insulin therapy and strong control has a high mortality. So we do not in adults and children. Children, there are a lot of growth spurts. So we have to adjust according to that as well. And CGMs work good in children because what happens is the trend. What I always say is look at the trend rather than following single readings and being paranoid about single reading. So if you have a trend which is showing decreased sugars over a period of time, then it's a good indicator because strict control has related to a higher mortality, long-term mortality. That is the intense insulin therapy. Now comes bariatric surgery. Bariatric surgery is an option when you've exhausted all the options. Okay, your lifestyle, your food, your exercise, everything is not working and you still have your overweight and diabetes and you have hypertension. So that is when bariatric surgery is indicated. In my personal experience, I have not advised bariatric surgery to anyone. So I would be the least, but there are lots of types of bariatric surgery done. The sleeve gastrectomy, the Roux-en-Y bypass, gastric bypass, which is commonly done. Then nowadays we have intragastric endoscopically. You put a balloon and reduce the volume of the stomach. Basically, if the volume of the stomach is reduced, you eat less, and when you eat less, there are less calories and there is weight loss. Now, I think it's an extreme step before you give in your best for lifestyle medicine, you know, like including all the pillars, like especially the nutrition one. And then you go in for bariatric surgery. Now, there was this January 24 meta-analysis in the journal called Obesity, which showed that at the end of 5 years after bariatric surgery, the weight regain is almost 49%, means 50% of the patient would regain their weight. And in Roux-en-Y gastric bypass, it is highest, it is around 64%. So it is not a cure, you know. It is not a cure. And if you're going to regain that weight, you're going to get those problems of diabetes and obesity and everything back. So that is an issue. Plus the post-operative immediate surgical complications, the post-operative, you know, nausea, vomiting. There are a lot of other complications that are there. They're like anastomotic leak and, you know, what are the procedure done? Now, Asians, because they're short and they have more of abdominal obesity, there was a study done in Singapore where this intragastric balloon dilatation, they used to do balloon, and because that's a non-invasive, means you don't have to cut, you know, there is no port or, you know, cutting on the abdomen. But Asians tolerate this procedure very poorly. Like, you know, sometimes they have so much of abdominal distension, even though the volume of that balloon inflation is less. So the results were not very good in the Singapore study. Then you have, you know, it's very expensive. In India, it costs anywhere between 2 lakhs to 5 lakh rupees. And there are a lot of other factors which are involved in bariatric surgery. Like how many years you've been obese, what is your lifestyle like, what are the comorbidities like, what lifestyle changes are you committed to do after? Because if you're not committed to those lifestyle changes, you will regain the weight and the disease is going to come back. So whenever I encounter my patients in practice, I always take the time out and say, okay, do you have other risk factors like family history of heart disease, family history of hypertension? That is one important thing. Second is, are you willing to make these lifestyle changes? As Dr. Rajendra said, commitment is extremely very important. Are you concerned about taking a pill probably for the rest of your life? Or are you concerned about the adverse effect of the pills or injections? So these are the questions that I put forth, and let the patient choose whatever is the option. See, I give them the pros and cons of medication, that is metformin or whatever sitagliptin or this sitagliptin, or for that matter, this, what is this, GLP-1 receptor agonists. See, GLP-1 receptor agonists are very expensive. I have not prescribed them to children. I have just seen adverse effects with Mounjaro and Ozempic for the patients that I've consulted. So that is as far as drugs and this thing goes. So my first attempt is always lifestyle medicine. At the most metformin with either sitagliptin or those dapagliflozin or empagliflozin. Those combination drugs are the drugs that I use in my practice. And believe me, the new patients, if they do lifestyle medicine changes, the remission is extremely very fast. I have seen sugars normalizing as early as like 7 days, 9 days. So you really don't need to start medicines. Patients who are already on medicines also, reduction in dosage is possible. And depending upon the commitment to lifestyle medicine it depends. So we do see adverse effects of GLP-1. It is extremely expensive. You have to explain the patient regarding the cost. As Dr. Rajendra said, they spend around 15 to 20 lakhs in a lifetime. And I personally would recommend lifestyle medicine first, along with metformin for obese patients. And for type 2 diabetes, of course, if it is type 1.5 or that LADA, where you have a low C-peptide and you have some antibodies positive, then it is a different scenario. Then you would, and if it's not, whether the patient is obese or not obese, according to that, you may start insulin therapy or you may start drugs and see how is the response. Okay. So I see
Okay,
type 1
ma'am.
diabetes a lot. So
What's the ma'am? Yeah, I think yeah, it's time. Can you please edit in 1 or 2 minutes?
yeah, so
Thank
that's
you.
it. So these are the 3 modalities that we explained. You give the choice to the patient. Let the patient decide what is the best thing that he or she can follow. Explain the pros and cons. And I'm sure a lot of patients would definitely choose, like, at least give a trial towards lifestyle medicine. Okay.
Thank you so much, ma'am. Dr. Vindhya, ma'am, you can ask the next question.
Thank you, Dekshana. So the next question will be for Dr. Suresh Bagge, sir. So how could we predict and quantify the diabetes remission rates in diabetic patients? Are there any score systems or methods available for it? And does it have any significance for people living with diabetes who are adherent to lifestyle modifications, including the evidence-based nutrition? Over to you, sir.
Yes, thank you for the question. And here comes the answer. So, a reversal of diabetes has been defined as the maintenance of HbA1c under 6.5 for a prolonged period of time without the use of any medications for glycemic control. Many people think that reversal is like remission. So, the first definition of type 2 DM remission came by Buse in 2009, stating that remission is the achievement of a glycemic level below the diabetic range in the absence of any pharmacology or surgical therapy. Then in 2019, this was revised by Nagy, and he said that the achievement of glycemia lower than the threshold currently used for the diagnosis of type 2 diabetes mellitus, which is sustained for a minimum of 6 months after discontinuation of all glucose lowering therapies. Then came Kalra, and wherein type 2 diabetes remission was defined as a healthy clinical state associated with the achievement of HbA1c below the targeted threshold, which is maintained for a minimum of 6 months, with or without the use of metformin and or lifestyle changes, provided the condition is not due to comorbidities or concomitant therapies or complications. And then recently the consensus has been by international experts convened by the ADA, American Diabetes Association. They say remission is a sustained metabolic improvement in type 2 diabetes to nearly normal levels, and they defined HbA1c levels to less than 6.5, which occurs either spontaneously or after an intervention, and which persists for more than 3 months in the absence of usual glucose lowering therapy. So that was like remission, the definitions of remission. Then we have got quantification of diabetes remission. Also, it is good to mention that partial diabetes remission is defined as HbA1c less than 48 millimole or fasting blood glucose less than 6 millimole. This is like the British standards. And complete diabetes remission defined as HbA1c less than 5.7% or fasting blood glucose less than 5 millimole. And remission markers which were used were like DIREM score, which was developed for predicting remission rate in persons with type 2 diabetes mellitus. And the scoring system is based on parameters such as HbA1c, insulin usage, age of the patient, and medications used. And they have given a scoring system from 0 to 22, and they have divided into different levels, like 0 to 2, 3 to 7 according. Then there was a diabetes surgery score, or the ABCD score, wherein A stands for age, B stands for BMI, C stands for C-peptide, and D for the duration of diabetes. And for the duration of diabetes, C-peptide levels, and for BMI, a 4-point score ranging from 0 to 3 was used, and for age, a single point, 1-point score was used. And then you total up the score ranging from 0 to 10 points. Higher scores predicting a higher probability of remission following gastric bypass surgery. And then one more can be mentioned, that is IMS score, or individualized metabolic surgery score, that is devised to guide the selection of procedure for individuals with type 2 diabetes mellitus based on long-term glucose control more than 5 years. And the nomogram for score calculation is based on the 4 predictors of long-term remission, that is the number of diabetes medicines used, duration of diabetes, insulin use, and glycemic control, HbA1c less than 7%. Score of less than 25 and more than 25 accordingly is mild to severe disease respectively. And in between is moderate, 25 to 90. And they have seen that those people who had fewer anti-diabetic medications, they had stronger predictors at 12 and 24 months. Higher systolic blood pressure was a predictor of remission at 12 and 24 months. And weight loss was the strongest predictor of remission at 12 and 24 months, irrespective of BMI, and percentage weight loss were equally good predictors. So, and then the last one is, so everybody talked about EBN. So EBN definitely, I mean, gives rise to a remission. And with that, I think the questions are answered. Thank you.
Thank you, sir, for the insights. The next question, we'll move on to the next question to Dr. Anjali Natra, ma'am. Ma'am, the current remission.
Yeah.
Hello.
Yeah, I'm there. I'm
Yes, ma'am.
traveling, stuck in a traffic jam. So sorry for the
Okay, ma'am. Sure, ma'am. No problem.
no video. Yeah.
Hope it's audible.
Yeah, absolutely.
Okay, ma'am. Okay, ma'am. The current remission criteria are based in part on HbA1c values. So in achieving these HbA1c levels, all that is required to prevent diabetes-related health problems, or is there more to it that we should be aware of, particularly in regards to chronic hyperglycemia in the past and metabolic memory? Furthermore, we would like to know if there's a risk of overtreatment associated with normalizing HbA1c levels, and if so, in order to mitigate it, what are the diagnostics like CGMs and interventional options available for us?
So thank you for the question, and thank you for inviting me for the panel, for this wonderful panel discussion. So coming to the question, so we have been using HbA1c as an average value of 3 months blood sugar, and it is measured by the glycated hemoglobin molecule. And the RBC life being 120 days, this is what we, it gives us an average of 3 months. So, but it does not give us the extent of the highs and lows of the blood sugar values. I mean, if it could be going very low at one point of time, going very high at one point of time, all we are looking at is the average. And these are very important because controlling these peaks and troughs has a bearing on the long-term metabolic health and the prevention of complications of diabetes. So the impact of the strict diabetes control was seen in ACCORD trial, which had to be terminated prematurely as the overall mortality was higher in the control group, in the intensive group, compared to where they were the HbA1c target was 6%, compared to the other group where it was 7 to 7.9% was the target control value. So they found that over 3 years the cardiovascular mortality and the overall mortality was higher in the intensive group, so they had to terminate the study. So apart from this, risk of seizures, brain fog, fainting, coma, which happens with an acute hypoglycemic episode, the repeated spells of hypoglycemia, prolonged spells of hypoglycemia can lead to multiple organ failure. They can lead to cardiac arrhythmias or cardiac arrest, and even permanent brain damage. So while it is good to have a good glycemic control in diabetes, it is also important to quantify where where the control is, and of course what are the highs and the lows. Now, hyperglycemia, on the other hand, when we talk of the highs in the blood sugar, it's responsible for the microvascular and the macrovascular complications of diabetes. Now, uncontrolled uncontrolled hyperglycemia in early diabetes, this was studied long back in the DCCT trial, and was followed up by the EDIC trial, which is Epidemiology of Diabetes Control and Complications, which was a follow-up of the DCCT trial and the UKPDS trials. So they showed that persistent adverse consequences arise when there is an exposure to hyperglycemia. But they also found out that even after the metabolic control is improved, the glycemic control is improved, there is a memory in the metabolic memory in the cells. And the persistent cellular changes, they represent a memory of an earlier metabolic state also, even after normalizing or controlling of the blood sugars. This is called metabolic memory or the legacy effect. The UKPDS named it as legacy effect. So subsequent investigations also revealed the biological impact of the metabolic memory peaked during the first decade, and then it subsequently waned off. Reason of this metabolic memory is the low-grade inflammation. It plays a very significant role in the metabolic memory. Sustained inflammatory response, oxidative stress, all these contribute to vascular complications. And the other methods which contribute are, the epigenetic modifications, the methylation, the histone modification, the microRNA, the impact on microRNAs, increased release of reactive oxygen species, the metabolic and the metabolic end products, and especially the advanced glycation end products. And in fact, the main studies have shown that main contribution of developing metabolic memory is comes from oxidative stress and the advanced N-glycation products. When there is impact of low-grade inflammation on, vascular remodeling, fibrosis, all of those things, they're all there, but the major contribution comes from these two processes. So to address this issue, there was like, what else can we do? So then came in time in range. Now, time in range, especially with CGM, I mean, with glucometer also you can do time in range, but how many readings will you take? CGM makes it very simple and very easily calculable. So time in range is a parameter which has taken over from that perspective, especially with CGM. It tells us this time spent in the optimal, control, which is defined as 70 to 180 milligram percent for most patients of type 1 and type 2 diabetes. And the time in range should be 70%, which is normally about 17 hours of the day. There should be, the blood sugar should be in this range. The rest of the control is like the hypoglycemic range and the hyperglycemic range. The hypoglycemic is like the level 1 is 4%, which is below blood sugar below 70 milligrams per deciliter. And the level 2 is, less than 54 milligrams per deciliter. And that should be 1% or less. Similarly, for the hyperglycemia, less than 25% of the time, the blood sugar should be above 180 milligrams per deciliter, but less than 250. And 5% of the time in range value can be above 250, which is the level 2 of hyperglycemia. So these are, so we do want the blood sugars to remain in good control, but lifestyle modifications have a very positive impact on, like Dr. Varsha said, Supraja said, that we by including fiber, we can slow down the response or the absorption of glucose. We can improve the metabolic milieu because of the improvement in the gut microbiome, which also has a very positive impact on the metabolism, which can also has an impact on the absorption of sugar, the fatty acids and all. So this becomes a very important factor. And of course, the lifestyle, following a good nutrition or lifestyle can also have an impact. I mean, we can highlight to patients that, see, you won't go into hypoglycemia. You would prevent hyperglycemia, but there is no risk of going into hypoglycemia when you are following intensive lifestyle program compared to when you're on drugs. So I think this is the impact of, this also helps us to tell patients and to explain patients the, why they should follow lifestyle modification as a primary primary way of managing diabetes and maybe even looking at diabetes remission.
Thank you so much, ma'am. My next question is to Dr. Achyutan Ishwar, sir. The question is, even if beta cell reserves in type 2 diabetes eventually begin to decline in the initial stages, the disease condition is primarily due to insulin resistance. Contrary to this, in type 1 diabetes mellitus, where insulin deficiency is the main culprit, could it be possible to achieve the remission state? And if that is not possible, then to what degree can we expect disease control with the best available treatment? And what part does EBN play in that process? Also, is it possible for GDM to remit or reverse? And if so, how can that be accomplished? Over to you, sir.
Thank you so much for that question, and it's truly an honor to be here. I want to share the story of my patient He was a 4-year-old boy. His parents brought him to me, I think about 2 weeks after he was diagnosed with type 1 diabetes. See, unlike type 2 diabetes, which most people have, type 1 diabetes comes usually in childhood, and it's an autoimmune condition where the beta cells in the pancreas, they get wiped out. So there is no insulin, not enough insulin circulating in the body. So whatever you eat doesn't go to your cells. It gets stuck in the blood and your glucose levels start going up. 2 weeks after he was diagnosed, his parents brought him to me and they said, can we do anything? He's currently taking insulin injections every day, 3 times a day. And it's so painful to watch, especially giving injections 3 times a day to a child. Forget about giving injections like once in 6 months when a child falls sick itself. It's such a stressful experience. Giving it every day is very, very difficult. So we started them on a plant-based diet and lifestyle changes. 6 months later, I get a call from his mother saying, Doctor, I have some great news to share. We have completely stopped insulin and his sugar levels are completely normal. I was so happy. Absolutely normal sugar levels. It's almost like he didn't have diabetes at all. And he was not taking any medications. Now, unfortunately, this is not a cure for type 1 diabetes because this is called the honeymoon period, where for some time, for a few months to few years, you'll be able, in some patients, you'll be able to bring them to something that seems normal. So instead of starting insulin at 4 years, we have postponed it to 6 years or 8 years or 10 years of age. Few years later, he may need to once again start insulin again because his beta cells are not working enough anymore. But postponing insulin by 2 years in a 4-year-old child, that's amazing. I'll take that as a win. And let's say after 10 years old, that child starts taking insulin injections because his own insulin production is simply not enough anymore. Now, is it possible to completely reverse this condition? No. And because it's not possible to reverse it, why bother with diet changes? I say that's why it's so important, much more important than type 2, to make those diet changes. Because imagine if there's a problem that can be fixed and you eat a healthy diet and you're able to fix it, okay, well and good. If there's a problem which cannot be fixed fully, you need to do everything in your power to reduce the damage as much as possible. Because for patients with type 1 diabetes, the sugar levels are a daily problem, but it's not the biggest problem. The biggest problem is risk of heart disease, risk of kidney failure, a risk of blindness, these complications which set in very early. By the time they're 20 years old, 30 years old, sometimes 40 years old, for some people, if they're lucky, all these complications start setting in. And how do you prevent these complications? Medications and with a healthy lifestyle. It's very, very important, even more crucially important than for type 2 diabetics. It's very important that type 1 diabetics eat a healthy diet, eat a whole food plant-based diet, eat a balanced diet, and use their diet and lifestyle to not only keep their sugar levels in a normal range, but to stay healthy and literally live a longer life, healthier life, and a happier life. I hope that answered your question. If you have anything more to ask, I'll be happy to explain. Thank you.
Thank you so much, sir. Any other panelist would want to add on this?
Yeah, I have also seen 2 cases of childhood diabetes go into the honeymoon phase, which it has been around 2 years. This November, they will complete 3 years and they still are off insulin. The signs of recovery, other than no insulin requirement, is increase in the C-peptide levels, which we monitored. So there is some, there is a good increase in C-peptide levels in both these patients, and there is a decrease in the antibody levels. The antibody levels which have gone down from the previous values. So one of them was post-vaccination, not post-vaccination, post-COVID infection that the child developed diabetes. And the other just out of the bolt, both were admitted with diabetic ketoacidosis. And over a period of say 3 months or 6 months, 3 months and another 6 months, after going whole food plant-based, especially removing animal products. One was a doctor's child, one is a doctor's child, hardcore Bengali, so fish, eggs, everything removed from the diet, and insulin requirement went 0. But of course, this is not a cure. This we see rarely. Whereas there are other patients, similar age group, type 1 diabetes, but still on insulin. So this is definitely, we don't know how long the honeymoon phase will last.
Thank you so much, ma'am. Over to you, Vindhya, ma'am.
Thank you, Deshna. So we have come to the end of the question moderating session. Any questions from the audience?
Anyone else uses any additional medicinal plants for insulin?
Okay, looks like there are no questions. Anybody? Anybody is having any doubts, any questions?
Any additional?
Ma'am, would you like to answer Varsha ma'am's question?
Because I see, it's a process of learning. Amla has been researched for diabetes and lipid disorders. There's this research from the International Journal of Nutrition and Sciences, which says that anywhere between, there's a comparison between glimepiride versus amla tablet, which is 500 milligrams, 1 gram, 2 grams. And they were given to 21 over a period of 3 weeks, that is 21 days, and they saw reductions in blood glucose, 45% reduction in cholesterol, 40-point reduction in triglycerides, LDL cholesterol, and a 25% increase in HDL cholesterol. That was one of the papers that I went through. Then there was this Indian Journal of Pharmacology 2012, which again did the same trial of 500 milligrams of amla powder tablet given. And they also saw, especially with respect to reducing cholesterol and triglycerides in patients, along with reduction in sugars. So that is why one of my patients, an adult patient, actually went into remission along with faster with this thing, with amla tablet supplementation, and of course a whole food plant-based lifestyle. And amla is probably one of those molecules which reduces lipoprotein A. There is no drug other than evoclumab, which is very expensive and twice-a-week injections. So evoclumab, lipoprotein A, amla is supposed to reduce that lipoprotein A. So I would like to just know if anyone uses amla in treatment or along, not as co-treatment, any additional medicinal treatment.
Actually, ma'am, in lifestyle medicine, those who are the certified diplomats of lifestyle medicine, they might know that in lifestyle medicine, the main approach is food patterns based or food group based rather than specific food or specific fruit or specific nuts or seeds like that. So
yeah, I completely understand that a single ingredient may not be helpful. This I just asked because there were a lot of people whom I knew actually working with this. So that is why I was just inquisitive if anyone uses it.
I think, Dr. Varsha, that's a very interesting insight that you've given, I mean, and definitely there's no harm, like, there's no downside. The way I look at it, if something can work adjunct to everything else that is being done, then why not? But
Yes, ma'am. I am also in agreement with Supraja, ma'am, that anything that is done in appropriate amount and appropriate proportion, that if that is helpful, we should lean towards it and try to research on that.
Yeah, see, the thing is, there is published literature on amla, basically, a lot of published literature on amla for diabetes, for cholesterol, for triglycerides. In alone, it will not work, but when it is along with whole food, plant-based nutrition and lifestyle changes, it definitely works. That is what I have also seen. So as we had discussed drugs, GLP-1 and intensive insulin therapy. So I just thought, why not this as an additional medicinal plant therapy, which may work, because I have seen it work. That is why I just thought of sharing it out here.
Dr. Varsha, any specific brand that you are advising? 500 mg you mentioned, right? So,
Yeah, right.
how many times in a day? And when you're suggesting, will you please guide us?
Yeah, see, so what I do is that Shri, the Art of Living tablets are available as 500 milligrams.
Mm-hmm.
So we start with one tablet. The only disadvantage of amla is you may have more bowel movements because it is also increases digestibility and all. So if the patient tolerates it, we go to 1 gram. Maximum is 1.5 gram. 1.5 to 2 grams is for high cholesterol and high triglycerides, provided the patient is committed enough to stop oil and, very minimal oil or stop oil when that stage, then these things help. I use this even for patients with elevated lipoprotein A, along with coenzyme Q and one more, Q10LC, carnitine. So, because patients cannot afford evoclumab for, every 2 weeks taking injections, getting admitted to the hospital. And we know that rosuvastatin and fenofibratin do not work on lipoprotein A. And it's a very huge risk factor for sudden death. So, lipoprotein A is somewhere where we use amla, lifestyle modifications, along with coenzyme Q and carnitine supplementation. And I have seen those levels come down.
Okay. So for CoQ and cortisone, any specific supplements that you're recommending? Specific
There's
brands
this
that you can see?
brand called Q10LC. So
Okay.
if you're interested more, you should read this book. This is Dr. Khan's book. I forget the name. He had mentioned this. And Dr. Rajendra, doctor from Coimbatore, he shared this with me. And after that, I started with this in preventive, this thing.
Okay. Okay.
So it's Q10LC, which is coenzyme Q with levocarnitine.
Okay. Thank you.
Thank you.
There is another question in chat box. What are the challenges faced for continuing whole food plant-based diets by the patients? From Divya Prabhu.
So,
what are the challenges faced for continuing whole food plant-based diets by the patients?
Yeah, so Divya, what typically the patients face the challenges is, the food that is cooked at home. If it's one individual, especially if it's, the lady of the house, then, for her, cooking something different from the rest of the house becomes one of the primary challenges. Second, most people don't know, how to cook without oil or how to cook with less oil, or they think that food is not palatable. That's a very, very psychological kind of a thing, that food is not tasty if it's, not with all of these, if it's not high fat and high calorie dense kind of thing. So convincing patients to start gradually is a good way, to get them to stay motivated and committed on this. The third thing is like, not going into very fancy kind of things and telling them, oh, you need to do quinoa, oh, you need to do something else, oh, you need to do kale and those kind of things. Most people come with that notion. I think as clinicians, you'll have to look at, what is their current food habit and make changes to that so that it's not very different from what they're doing currently. So these are three things which you need to work on. If because there's lots more when you get into step by step. There are many things that come up, but the primary challenge that patients face is uh, and they think it's expensive. So that is another factor which most people come up with, which is where what they're doing currently, if we are able to modify that to bring in a more healthier, a more whole food concept to them, then that makes it sustainable. Varsha, do you want to add anything?
Yeah, so when we start with a new patient, we add in, like Supraja said, add salads with your meals, add more raw, add like 2 to 3 servings of fruits. And then gradually something that is not good will automatically get cut out. So the more you add, the unhealthier stuff automatically gets cut out. And the second challenge is, when you socialize, when you travel out, that is the time when, it is a bit of a challenge. But either you carry some stuff, roots are always available, almost at most of the places. So gorge on fruits and, like something like, try to be as near something like dal chawal would be available almost everywhere. So that is how we guide our patients. You also asked for recipe books. Recipe books, that was the message that I saw in one of the chat, this thing. So PAN also has its recipe book. The soft copy can be shared.
Also, there are websites which give you if you just Google in whole plant-based recipes, there are quite a few websites which can give you that information. So but very simply, whatever you're eating on a daily basis, right? All you need to focus on is like, how do I cut out the fat, which is the oil part predominantly, and the refined foods, right? So substituting with the fiber dense option, like for example, replacing or substituting your white rice with unpolished brown rice or red rice, those kind of changes should help you making your dal, doing a dry tadka to your dal or sambar. So these are simple things that is easily possible without any fancy recipes.
One more problem that I usually face with my patients, especially who are in their early stages of behavior change, that they feel they fail because they don't find it that much tasty compared to ultra processed foods. So in that case, my main tool is motivational interviewing and including the family members as a support team for them. But currently, I have only these tools to deal with this problem, and continually motivating patient to have patient at least for a month um, to see the changes in their test responses. Can you please, if you have any other strategies, can you please share those, ma'am?
Yeah, so 1 minute. Hello. Yeah, so what actually ultra processed food is extremely addictive. It takes time. What I personally feel, it's an undernourished, overfed body which is craving for ultra processed foods. So the more nutrient dense food that you take, the gradually your cravings do die down. The cravings which do not die down very easily are, in my experience, of two things. One is coffee and second is cheese. These are the two cravings which really take a very long time to die down. And rest of the things do take time, but if you hyper nourish your body with the highest quality ingredients of nutrient dense food, then the cravings do definitely go down over a period of time. And we have to understand one thing: we are surrounded in a world of ultra processed foods, like when you go in the train or you are at somewhere, even in the most interiors of where like poverty stricken regions, you will find packaged food. And fresh food or fresh produce is still less. And fresh produce has to be made tasty. Ultra processed food is convenient, it is cheap, it is addicting, it is tasty. So we have to lead by example, especially parents for children and adults, because you really, like the more you consume it, you will never be full enough and you will always feel hungry because it is calorie dense and it does not satiate you. So you have to, just reinforce healthy eating behaviors and lifestyle modifications.
Can I come in?
Uh,
Yeah. Yeah. So I think another thing that helps is when we start initiating patients on whole food plant-based diet and like the additions, if we can tell them, just look at how you feel. You don't feel, low energy levels. It helps, to improve the mood. There are so many other benefits apart from, like looking at the weight or the blood sugar when we are initiating patients on the diet, on a whole food plant-based diet. I think that also helps patients because end of the day, having, feeling energetic, having, feeling good, being able to achieve more, not getting tired, all these factors. Also, if they start like looking at these factors, it is a good way to understand that yes, this is good for your body.
Thank you, everybody. So I think we have come to the end of the discussion part also. So let's move on to the summary. So the diabetes remission can be defined according to the ADA with no medications for more than 3 months and HbA1c below 6.5%. And the criteria for remission, the patient who we select for should be he should be good fit and diagnosed with diabetes within less than 2 years up to 10 years, but he should be within 10 years of diabetes diagnosis of diabetes. And the people who are not fit for diabetes remission are with a long-term diabetes mellitus for more than 10 to 15 years and other complications. And the diabetes remission can improve the lifespan. Next, like the ultra processed food, like the diabetes remission can be made like by avoiding ultra processed foods and cutting down refined foods and cutting down extra fat and calorie deficit diets and adding more fiber to the diet and other lifestyle modifications needs to be addressed to manage insulin resistance and in the remission of the diabetes. And in modalities of diabetes remission, other modalities are effective, but comes with more adverse effects and cost effectiveness. Cost effective like for the Indian population, and hence lifestyle modification will we can consider it as the first line of treatment. And even after achieving HbA1c level to pre-diabetes level, cells contains metabolic memory, which is nothing but the result of sustained state and oxidative stresses and AEG products. To mitigate this, Dr. Anjali ma'am provided us information on monitoring strategies and again highlighted the importance of evidence-based nutrition and lifestyle interventions in the management. And type 1 diabetes and type 2 diabetes remission, in both aspects, there cannot be complete remission, may not be, but if possible, but we can postpone it, and with intensive pharmacological therapy, and also we can postpone the complication. We can postpone the pharmacological therapy and the complications of diabetes by embracing the healthy lifestyle and medications whenever necessary. And coming to the scoring system, like how we predict and quantify the diabetes remission, Suresh sir has told us given us several scoring systems which can be used in predicting and quantifying the diabetes remission. Thank you so much, everybody, for joining us, and we move on to the vote of thanks. And we thank you all the audience for your keen interest in and joining us in today's discussion forum. And we thank you all the speakers, today's speakers, Dr. Rajendra, Supraja, Dr. Vasha ma'am, Dr. Achyutan, Dr. Anjali ma'am, Dr. Suresh Baghe sir. Thank you so much. And we thank you, Dr. Rajina ma'am, and Amrita ma'am, and yeah, etc., for giving us this opportunity. And yeah, let's end today's session. And thank you all the speakers for giving us all insightful points which we can take.
Thank you, India. Thank you.
Good night. Good night. Good
for
night.
a lot of thanks, and good night, everyone. We will meet again next month on the 4th Thursday with another topic on diabetes. Till then, goodbye and good night.
Thank you. Good night, everybody.
Good night.